for giving me the opportunity to come and talk on the golden hour management of trauma patients and what do we mean by golden hour? Anyone? What do we mean by golden hour? Sorry? Yeah. Yeah. It's the time when you receive the patient. It doesn't mean that it starts when the accident has taken place. A patient comes to you after 2 hours and you say, no, your golden hour has passed. His golden hour actually started when he came. So I had this, I am teaching ATLS and I'm a course director and I taught ATLS abroad as well in Riyadh, Saudi Arabia, and I worked there. This is National Guard emergency where I worked for 3 years before I came back. And this is the helipad which is there, and this is the ER. And this is the research unit where all serious trauma patients are brought. And this is one of the research bays. One of the research bays. These are the central monitors, and this is the sitting area for the doctors, and all around are the research bays. And so this is the trauma code activation guideline for trauma code activation. I'm sorry about the image, but they're all printed documents. So everybody knows when to activate a trauma code, and it's announced all in the hospital. I mean, you hear it from the overhead voice messaging system that there is a trauma code activation, and everybody rushes to the research unit and you manage your patient. So trauma team generally, they consist of general surgeons, they consist of orthopedic surgeons, there are resuscitation unit nurses and recording nurses and respiratory technicians for setting the ventilators, and then the trauma team, which is headed by the general surgery team and the consultant surgeons. They call various other services, EFT, IE, OMF, ICU, whoever they need, and it's important to take universal precautions. So one of the earliest and the most important thing in managing a trauma patient is ensuring and securing an intact airway and recognizing compromised airway. This is of utmost importance. And early endotracheal intubation with neck stabilization is done in patients who have maxillofacial trauma, who have facial and upper dorsal burns, who have severe head injury of 8, GCS 8 or less than 8, who have severe chest trauma, flail chest, who have trauma with cardiorespiratory arrest, and any patient who is being managed and deteriorates suddenly, trauma code will be activated. So what we do in trauma bay after we have received the patient is we try to take care of the immediate life-threatening injuries, and they involve relieving a tension pneumothorax, managing a chest pneumothorax, passing a chest tube, pneumothorax with chest intubation. If there is any external bleeding, you will apply direct pressure, packing and dressing, applying pelvic binders, and stabilize the fractures. So for tension pneumothorax, where do we do the needle decompression? Sorry? Fifth intercostal space. Where? Sorry? In mid-clavicular line, anterior axillary line, mid-axillary line, where? Second, no. It's staying now. It's fifth intercostal space, just in front of the mid-axillary line. And it's the same place you pass the chest tube as well, the tubes are passed. But for children, the guidelines are the same. According to the 10th edition of ATLS, it is the second space for children and fifth space for adults. So once you have passed the needle, you have done the needle decompression, then you pass the chest drain. And these are very simple procedures. People can die because of pelvic fractures. Whole of the blood volume, 5 liters, can just go into the pelvis, and person can die because of this. So this can be managed very easily by applying a pelvic binder, which you can make from a simple sheet, you know. You can make it from very simple things. So intravenous access. This is the next thing. Once you have secured A and B, the next important thing is C. And one of the most important thing is to secure intravenous access with large cannulas, 14 or 16 gauge, and you give fluid. Which fluid you want to give? What fluid you want to give? Warm, saline or renal lactate. And now they say that don't give more than 1 liter. Maximum is 1.5 liter, because if you give more than 1 liter of crystalloids, and the morbidity and mortality rises for the trauma patient. And we just understand why it rises. And once you have given 1 liter of this crystalloid, which is warm renal lactate, warm is very important. It's very important for the trauma patient who are losing heat and who are coagulopathic. Because of trauma, 30% of these patients are coagulopathic and they are acidotic. So it's very important that you don't worsen this coagulopathy by giving cold fluids, and you don't give lots of crystalloids so that the clotting factors don't dilute a lot. Next important thing is, once you have given 1 liter of this crystalloid solution, you give bagged RBC, which is O negative blood. It's class 1. It's called class 1. In the trauma centers, there is a freezer in the ER. The research that I showed you, there is a freezer there, and it has stored O negative blood, because patients' blood will be available in about 1 hour's time. Once you put an IV line, you take a sample for grouping and cross-matching, and you send the blood back. It will come back in about 1 hour. So in the meantime, you have O negative blood available, bagged RBC. So once you have given 1 liter of saline, crystalloid, you just start giving bagged RBC, if you think the patient needs it. So tranexamic acid, there is a big trial, crash trial. This was the topic. You can read it, and it said that if you give tranexamic acid within first 3 hours of any blunt or penetrating trauma, it doesn't matter. The patient morbidity and mortality is greatly decreased from this because of this trauma. And this has, the tranexamic acid is given when? When do you give tranexamic acid? Sorry? Yeah, but at what time? The timing is within the first 3 hours. This first 3 hours, 1 gram in the field. And once you have given 1 gram in the field, then once the patient comes to you, you give another 1 gram over the next 8 hours in an infusion. So if the patient comes after 4 hours, don't give it, because then the morbidity and mortality rises. So what tranexamic acid does? What does it do? So tranexamic acid basically combines with plasminogen, and stops its conversion into plasmine. And this plasmine actually breaks down fibrin. It breaks down fibrinogen to fibrin. So once you block plasminogen and don't let it convert to plasmine, the clot stabilizes. And this is so important in trauma patients, so that you have a stable clot so that the bleeding stops. So this is what tranexamic acid is doing. So it's an antifibrinolytic, as I said. It reduces the rate of risk of mortality and morbidity in both blunt and penetrating trauma, and it binds reversibly with lysine receptors on plasminogen and stop it from becoming plasmine, which breaks down fibrinogen. And severely injured patients, so 30% of all trauma patients who come with trauma and who are bleeding have acute traumatic coagulopathy. They are coagulopathic. They are acidotic because their metabolism is anaerobic at this point of time, and there is lactic acid in their circulation. They are acidotic, they are in shock, and they are hypothermic, which is the lethal triad. So we need to give them warm saline or warm crystalloids, warm blood. We need to warm them as well so that we don't worsen this coagulopathy. And we want to give them crystalloids which are warm but not more than 1 liter, because we don't want to cause dilutional coagulopathy. If we keep on giving them crystalloids, this will cause dilution of the whole body circulatory system. The blood, it will become diluted. The clotting factors are already being consumed, so the coagulation will worsen. So as I said, the tranexamic acid, the studies, now there was another trial, crash 3 trial, and they said that you can give tranexamic acid even in severe head injury patients, and it improves the morbidity and mortality in patients with head injury. So EFAST, what is EFAST? What is EFAST? So right upper quadrant and left upper quadrant and pericardium and around the bladder. ये फास्ट था, तो फिर उन्होंने इसमें एक ऐड कर दिया, they just added प्लूरा को देखने के लिए कि प्लूरा लंग जो सा है उसमें न्यूमोथोरैक्स तो नहीं है, so this is extended fast. So this is, if you can see, this is the liver. फास्ट में ये राइट अपर क्वाड्रेंट है, ये लिवर है, ये किडनी है, इनके बीच में देयर इज नथिंग. लेकिन जब ब्लड होता है तो फिर ये ऐसे ब्लड बीच में आ जाता है, ब्लैक सा आपको इमेज नजर आता है. So this is fast positive in the right upper quadrant, and this is for the left upper quadrant. This is spleen, this is the kidney, and this is blood between the kidney and the spleen. And this is the subdefault pericardial view, and you see this is normal. This is the pericardium, this is beating hard. But when there is blood between the pericardium and the heart, this black line, you can see a space here. This is positive pericardial fast. And this is one of the images. You see this line moving. This is the visceral, the interface of visceral and parietal pleura. If you see this line moving, it means the lung is expanded. But once this stops, it means there is pneumothorax in this person. So another very important thing which you see in trauma patient is cardiac injury. So it's easy to pick up cardiac injury in penetrating trauma, because if you have a penetration in the cardiac box, you know there is a penetration. There might be heart disease, but it is more difficult in blood trauma. But if you see a patient whose heart rate is fluctuating, sometimes it's very high, sometimes it becomes very low, the patient becomes bradycardic, there is no obvious bleeding source, and sometimes you start getting atrial fibrillation. So there is very high chance that the patient is having blunt cardiac injury. And if there is no clear evidence of fast scan, positive fast of hemopericardium, it's important you call the cardiac surgeon and take a consult. So once you have given 1 liter of saline to your to your trauma patient and back RBC is cleared, and he responds and you label him as a stable patient, then all these patients should go for contrast enhanced CT scan, which is a trauma CT scan. And once you have done this trauma CT scan, you review it with the radiologist. It's very important to go and sit with the radiologist and find what type of head injury he's having, what type of orthopedic injuries he's having, what type of chest or abdominal injury he's having. So it's all basically initial responsibility of the general surgeon to understand all these injuries. And all hemodynamically unstable patients who are unstable, they will go to OR. They will not go for any investigation. They will directly go to the operating room. Their bleeding is stopped. And once the bleeding is stopped, they are admitted back to the ICU. And from the ICU, once they are stable, the contrast enhanced CT scan will be repeated to know about the injuries they are suffering from. And what is the role of interventional radiologist? It's very important patients who are stable on initial management. You do their contrast CT and you see if there is any contrast flush from the liver, the spleen, the pelvis, the muscles. So you just, if there is any contrast flush, which means that there is a leaking contrast, which means there is bleeding going on, then you ask your friend, the interventional radiologist, to stop that bleeding. And they can stop that bleeding with the help of coils and all those things. So what is diagnostics? It's very important. Diagnostic laparoscopy is more of a diagnostic thing in present. It's one of my patients. I did a diagnostic laparoscopy on him. He was a patient with blunt trauma, and what is this? ECAD. This is seatbelt sign. So what if there is a seatbelt sign? It's very important to pick these things. There are high chances that he might have an injury of the intra-abdominal bowel. He might have a chance fracture, which is fracture of the second lumbar vertebra because of seatbelt, and they have associated bowel injury. So you do diagnostic laparoscopy to rule out all these injuries, and if you have a stab to the abdomen with unequivocal signs, it's better to do a diagnostic laparoscopy and have a look inside rather than waiting for something to develop. And then if on CT scan you find fluid within the peritoneal cavity and you want to be sure that this is not bile or anything which is related to the bowel, you can do a diagnostic laparoscopy. So once you have stabilized your patient, all trauma patients who have life-threatening injuries, they are evaluated for ICU admission, and ICU doctors, they pass in IV lines, and if they need isotopes as well. All patients, they are started, even if they are bleeding, but their bleeding has stopped, they are started with DVT prophylaxis in 48 hours. Patient who has a liver laceration, who has a splenic laceration, who was bleeding from the mesentery, once their bleeding has stopped, with the help of intervention radiologist, or it's stopped by own, then in 48 hours you will start with heparin and low molecular weight heparin. And then if you want to, you should take a neurosurgical consultation if the patient has a head injury or he has a spinal surgery. And you must take vascular surgery consultation for patients who have aortic injuries and they are being managed conservatively. So temporary IVC filter are very important in these trauma patients sometimes, mostly in patients with pelvic fractures and long bone fractures. And then patients who have liver, spleen and kidney injuries with hemoperitoneum and they are being managed conservatively, and you need to take them to OR for fixing their fractures. Patients who have fixed their spinal fractures, who have head injury, aortic injuries being treated conservatively, and they should be removed before the patient is discharged. This is one of the images where you place these temporary IVC filters. These are put by the intervention radiologist. And all patients, once they are stable, you start feeding in them. And you start feeding in the ICU as soon as possible. And you start feeding with clear liquids, and then you go on to the full liquid diet and soft diet and regular diet as the patient tolerates. And then you aspirate the nasogastric tube or the feeding tube every 4 hours. If the aspirate is high, more than 200 ml, you hold the diet or you reduce your feeding or you add a prokinetic one. But if it is less than 200 ml every hour, you keep on feeding the patients. It's just, this was no head injury, you can give a trial of feeding in advance in head injury. So one of the things which is not available here is the swallowing assessment which is being done. All severe head injury trauma patients, once you start feeding them, before you feed them, you assess their swallowing. So there are swallowing teams who come and assess their swallowing. And once they allow you that the patient can be fed, so you start feeding them. And then tracheostomies are managed by gradual downsizing and parking by ENT team. And there is role of behavioral medicine in these trauma patients as well, because sometimes they become very angry and upset in the post-trauma time. So in summary, early we will see spine control, manage life-threatening injuries in the trauma bay, warm ringer lactate, 1 liter, don't give it more than 1.5 liters. Early giving class 1 blood which is O negative, tranexamic acid not later than 3 hours. Unstable patients will go to OR, stable patient will go to CECT or interventional radiologist. Diagnostic laparoscopy, if you want to be sure about the abdomen, all are admitted to ICU, and you can start DVT prophylaxis, IVC filter in the next 48 hours and early Q3. Thank you very much.